Hey, welcome to the podcast.
Thanks for having me.
I've been reading about Sjogren's syndrome, and it's pretty wild. Like, it starts with dry eyes and dry mouth, right?
Yeah, exactly. Xerolophthalmia and xerostomia. Fancy words for everything dries up.
But wait, what actually causes it? Like, why does your body just decide to attack your own glands?
Okay, so this is fascinating. It can literally be triggered by viruses like Epstein-Barr or hepatitis C.
No way, really?
Yeah, so the virus infects the salivary glands, kills some cells, and then all these self-antigens get released. Your immune system sees them and goes, wait, what's this? And starts attacking.
So it's like the virus opens Pandora's box.
Exactly. And the specific targets are these proteins like alpha-fadrin and these ribonucleoproteins called Rho and LA.
Rho and La. Those sound like Star Wars droids or something.
Right? But in people who are genetically prone, their T cells and B cells see these proteins and just lose it. They escaped tolerance, basically.
So you need the virus, the genetic risk, and then boom, autoimmune disease?
Yes, it's like a perfect storm. Trigger plus genes plus broken tolerance equals inflammation and damage.
Okay, so that pattern, does that show up in other autoimmune stuff too?
Oh, totally. Like almost every systemic autoimmune disease follows that recipe. Environmental trigger, self-antigens, failed tolerance, and then chronic inflammation and fibrosis.
Huh. So what about those autoimmune polyendocrine syndromes? I've heard those are confusing.
Oh, man, yeah. So there's APS1 and APS2. APS1 is caused by mutations in this gene called AIR.
What does AIR do?
It's like the immune system's training program in the thymus. It teaches your T cells what's self, so they don't attack you later.
Wait, so if AIR is broken, your immune system never learns what's you?
Exactly. So APS1 patients get this triad: candidiasis, low parathyroid function, and adrenal failure. It's pretty specific.
And APS2?
That's different. More genes involved, more polygenic. You see thyroid problems and type 1 diabetes more often.
So APS1 is one broken gene. APS2 is like multiple genetic hits.
Yeah, exactly. Different mechanisms, but same idea. Lost tolerance somewhere along the line.
Okay, let's talk rheumatoid arthritis. I know people get joint pain, but what's actually happening here?
So you've got these autoantibodies. Rheumatoid factor, which is basically antibodies against your own antibodies.
Wait, your body makes antibodies against antibodies?
Oh, right? And then there's anti-CCP, which targets citrulline proteins. These drive chronic inflammation in the joints.
And that's where the cytokines come in?
Yes, so TNF-alpha, IL-1, IL-6, these are like the inflammation amplifiers. They just keep the fire burning.
So that's why TNF inhibitors work. You're literally blocking the fuel.
Exactly. And the balance is off too. You have fewer regulatory T cells and more of these like aggressive Th1 cells.
And it's not just joints, right? I've heard about lung and eye problems.
Yeah, RA can be super systemic. You get nodules, vasculitis, lung fibrosis, even secondary Sjogren's.
Man, that's rough. What about lupus? That one seems even more all over the place.
Lupus is like the ultimate multi-system autoimmune disease. It's all about excessive autoantibodies against nuclear stuff.
Like what, DNA?
Yep, anti-double-stranded DNA, anti-Smith, ANA, all these antibodies form immune complexes that deposit everywhere.
Wait, I read something about complement deficiencies causing lupus.
Oh, yeah. Also, if you're deficient in C1q, C2, or C4, your risk of SLE is like 90%. It's crazy.
Why though?
Because complement helps clear out dead cells and immune complexes. Without it, all that debris just hangs around and triggers autoimmunity.
And there's something about interferon too, right?
Yeah, about half of lupus patients have elevated type 1 interferon. It amps up antigen presentation and fuels the whole autoimmune response.
So the immune system is just on overdrive.
Totally. And the cytokine balance is off, more Th17, less Tregs, little IL-2, high IL-23. And clinically, you get the butterfly rash, kidney problems, neuro stuff.
Yeah, lupus nephritis is serious. Plus, antiphospholipid antibodies can cause clotting issues. Wait, so lupus can cause both inflammation and blood clots?
Yep, it's a double threat. Immune complexes everywhere, plus thrombotic risk.
That's terrifying. What about scleroderma? I know it involves skin hardening.
Yes, systemic sclerosis. It's this triad: blood vessel damage, immune problems, and fibrosis.
And Raynaud's is usually the first sign?
Yeah, exactly. Your fingers turn white or blue in the cold because the vessels spasm.
And there are different types?
Yeah, so there's limited and diffuse. Limited affects mostly hands and feet, progresses slowly. Diffuse hits the trunk and organs fast.
What causes it?
Environmental triggers like silica exposure, certain drugs, maybe viruses like EBV again.
So it's that same gene-environment interaction theme again.
Exactly. And there are specific autoantibodies, anti-topoisomerase 1, anti-RNA polymerase, that correlate with the subtypes.
So every autoimmune disease has its own antibody fingerprint.
Pretty much. It's like each disease has a signature.
Okay, so we've covered a bunch. Sjogren's, the polyendocrine syndromes, RA, lupus, scleroderma. What's next?
Well, we should probably talk about immunodeficiencies because they actually overlap with autoimmune stuff more than you'd think.
Wait, really? How does that work?
Okay, so here's the thing. When your immune system is deficient in certain areas, it can actually become dysregulated and start attacking you.
Wait, that seems backwards though.
I know, right? But it makes sense when you think about, like, if you don't have enough regulatory cells or if clearance mechanisms fail.
Oh, so it's not just about being weak, it's about being unbalanced.
Exactly. Balance is everything in immunology. Too much, you get autoimmunity. Too little, you get infections, but sometimes you get the both.
Okay, so I was reading about primary immunodeficiencies and wait, can we just start with like the big picture here?
Yeah, let's do it.
So these PIBs, they're hereditary, right? Mostly hitting people under 20, and the prevalence is like 1 in 300 to 1 in 500.
Yeah, and here's what's wild. There's over 300 of these disorders, mostly single gene problems. And get this, about half are B-cell issues.
Half? That's insane.
I know, right? Then you've got like 10% T cell, 20% combined, and another 20% are NK cells, phagocytes, or complement problems.
So that's why antibody defects are everywhere in these cases, because B cells make up such a huge chunk.
Exactly. So when we talk humoral PIDs, we're talking transient hypogammaglobulinemia, selective IgA deficiency, X-linked agammaglobulinemia, CVID, hyper IgM syndromes.
Wait, the transient one, that's not really a real PID though, is it?
No, not really. It's just that maternal IgG fades and babies catch up by like a year old.
Right. So mom's antibodies protect the newborns for what, 4 to 6 months?
Yeah, premature babies are more at risk, but most of these kids respond fine to vaccines and their levels normalize by a year.
Okay, but selective IgA deficiency, that one's weird.
Most people don't even know they have it.
Amusingly, yeah, totally.
Totally asymptomatic for a lot of them. But some get gut infections, sinus infections, and autoimmune stuff pops up more.
And here's the thing, you can't give them gamma globular or plasma, right?
Never. The IgA in donor plasma can trigger anaphylaxis in these patients. That's a big deal.
Wow, okay, good to know. So X-linked agammaglobulinemia, that's the BTK defect, right?
Yep. Bruton's tyrosine kinase. The mutation blocks pre-B cell signaling, so these boys have no mature B cells.
And they lose IgG, IgM, IgA once mom's antibodies wear off.
Exactly. Then they get hammered with recurrent infections from encapsulated bacteria, staph, strep, all that.
But you can treat it with regular gamma globulin replacement, subcutaneous or IV, right?
Yeah, that prevents those opsonization-dependent infections. Now contrast that with CVID.
CVID is like way more complicated, isn't it?
Oh yeah, it's super heterogeneous. Poor B-cell maturation into plasma cells, multiple immunoglobulin isotypes drop, and it usually shows up in the 20s or 30s.
So it's not just one gene?
Nope. Sometimes it's B-cell signaling genes like CD19, sometimes TB interaction defects. Clinically, you see infections, autoimmunity, even lymphomas.
And complications like granulomas, chronic diarrhea from giardia, malabsorption.
And increased gastric cancer risk in some cases. It's rough.
Okay, hyper IgM syndromes. That's the flip side, right? They can't class switch.
Exactly. IgM stays high or normal, but IgG, IgA, IgE tank. Usually it's CD40 ligand or CD40 defects.
And because T and B communication is messed up, you get lymph node enlargement, splenomegaly.
And yeah, GI lymphoid infiltration and yeah, malignancy risk too.
All right, let's shift to cellular and combine. DeGeorge syndrome, that's the 22q11 deletion, right?
In most cases, yeah. Thymic or hypoplasia, hypocalcemia from parathyroid issues, cardiac defects, facial features.
And the T cell deficiency varies a lot?
Yeah, partial forms have some function. Very rarely it's as bad as SCID, but if the thymus is really affected, you get fungal infections, severe viral disease.
Speaking of SCID, the bubble boy disease, there's so many molecular causes, right?
Oh man, yeah. ADA deficiency, common gamma chain defects, JAK3, RAG mutations, Artemis all lead to absent T cells and messed up B and NK cells, depending on the subtype.
And these infants just fail to thrive. Chronic diarrhea, candidiasis, overwhelming infections.
Yeah, and HSC transplant from an HLA identical sibling is often the cure.
Wait. But ADA gene therapy is a thing now, right?
Yeah, gene therapy and enzyme replacement for ADA SCID, it's a huge landmark.
That's wild. Okay, phagocyte problems. CGD is the classic one, right? NADPH oxidase defect.
Yep, no respiratory bursts, so catalase positive organisms just stick around and granulomas form.
X-linked GP91 FOX mutations are common. Patients get recurrent staph, Serrata, Pseudomonas, fungal infections.
And stem cell transplant can cure severe cases.
Then there's adhesion problems. LAD with CD18 defects, no pus, delayed cord separation, persistent neutrophilia.
Yeah, and LED2 and LED3 have other transport or integrin activation defects with extra features.
JDAC, Hashi's scary. Giant granules, albinism, neurologic issues, bleeding.
And that fatal accelerated phase in a lot of patients, it's brutal.
Complement deficiencies are surprising too. Depending on which component is missing, you get SLE-like disease, Neisseria infections, or angioedema.
Right. C1 inhibitor deficiency raises bradykinin and causes hereditary angioedema. Onset is often in childhood or adolescence.
Oh, and swelling episodes resolve as complement is consumed.
Exactly. Before we wrap up, Robbins gives warning signs in kids: 2 or more ear infections a year, 2 or more pneumonias, failure to thrive, persistent thrush, family history.
Classic red flags. Early recognition means IVIG, stem cell transplant, or gene therapy, and you prevent long-term damage. Okay, we covered a ton here. That was fun.
Yeah, this is great.
All right, catch you later.